Good evening, one and all. At the outset, I would like to thank Dr. Chitra and the ARC team for giving me this wonderful opportunity. The very first thing I had in my mind was that title given to me initially was, do all HLA B27 cases needs immunomodulators? I would like to speak against for this topic. But Dr. Partho felt that all has to be removed. You know the reason why. I would like to start my presentation saying that whatever I speak is truth, because I say what I practice, truth and truth, nothing else. I wish my opponent says the same. So this was a 52-year-old female, a known case of psoriasis presenting as unilateral recurrent anterior uveitis. The patient was referred to me to start immunosuppressant to prevent recurrence. On thorough probing, we found that the patient was using bisphosphonate as a treatment for osteoporosis. So, on suggesting the patient to stop this drug called bisphosphonate, which can cause drug-induced uveitis, there was no recurrence. There was no need for this patient to start on immunosuppressants. So, pay attention to the differential diagnosis of the disease, although the disease of psoriasis, which is or a subset of HLA B27 is obvious. So this was a wonderful article I came across, how to forecast whether the presence of HLA B27 or MRI is going to help in the diagnosis of spondyloarthritis. What it essentially says is, if you have HLA B27 disease suspect, will you do MRI or an HLA B27? The test, the results came convincingly that the probability of the positive MRI increases from 40% to approximately 70%. But miserably, the forecasting of HLA B27 fails. Not even any case definitions fail. How do you type the HLA B27? There are different methods. The PCR can eliminate the false results coming by flow cytometry and MLCT tests. So we need to pay attention to this basic elementary fact. In a proven ankylosing spondylitis or HLA B27 population, 80 to 90% of patients will have positive for HLA B27. That means the 10 to 20% will test negative. 10 to 15% people with HLA B27 gene end up developing ankylosing spondylitis. To me, this test HLA B27 looks like a paper pumpkin. For what are we doing? Is it useful for diagnosis or classification? Several criteria are useful for research setting, not for clinical practice. MRI of the axial sentinel or HLA B27 are important for the classification of the disease, and the negative findings do not preclude a diagnosis of spondyloarthritis. HLA B27 has a close tendency to be associated with AML as well, and even the carriers are associated with it. So in that scenario, your immunosuppressants can be detrimental as well. Most importantly, HIV infection AIDS is also associated with HLA B27 because infection with HIV predisposes to spondyloarthropathy. In fact, the class 1 HLA molecule is closely associated with the non-progression of HIV to AIDS. So you may not be able to detect HIV in HLA B27 in the early stages. So be very careful in starting immunosuppressants. Screening based on HLA B27 is a futile exercise. Bayer's theorem is useful. It is useful only in the Japanese population where there is a low prevalence. Time to delineate whether you are dealing with disease-associated subtype or non-disease-associated subtype. So Dr. Partho showed a case of HLA B27 mimicking spondyloarthritis. I also have a recent case where they treated without immunosuppressants and they suggested it may be required for a long time. So we do not want to start immediately on, even in a case of endophthalmitis type of presentation. When in dilemma, whether it is infection or inflammation, you will always err towards the site of infection. So that is a safer strategy. You will not harp in immunosuppressant, dear Partho. HLA B27 is not equal to JA arthritis. Immunosuppression is not the primary indication. Unlike JA uveitis, we have to rule out the differential in the false positives. We are living in a TB endemic country. Indications of immunosuppressants are neatly enlightened by the focus initiative by the recent article, where they clearly outline that the evidence and the recommendation level. And on thorough searching this article, I couldn't find out any mention on actually B27 on the disease entity, although it speaks of non-infectious uveitis. Dr. Pato is a man of principles. When I took my mom for his expert consult, he even asked me, gene proof, I am my mom's child. Why then you have to do HLA B27 for all patients of clinical suspect? I don't understand. If all HLA B27 needs immunosuppressants, then computers cannot be replaced, doctors. In the words of Shashi Tharoor, it is a very high degree of mischievous crude grass approximation in excessive. So when to decide on immunomodulators? This is a Roman journal of ophthalmology. I think Dr. Partho should be an Indian and he can't follow the Roman practice in India. And it says that when there is some speculated association with vitamin B2 and GLE is RS4752, if you do, then there is a risk of uveitis. The secret of learning faster is we should ask why not. This is a wonderful article from Korean journal which supports my argument. It says that there is no significant difference in the BCVA and the prognosis. It is a cross-sectional study. Group 1 is B27 negative, group 2 is positive. Look at the need for immunosuppression, 5.5% in B27 positive, and even in the subtype with systemic association, it's 6.9%, less than the 7.4%. Recurrence rate is not statistically significant, no difference in the BCVA. Argument's sake, let us assume immunomodulators are the treatment of HLA B27. What all can happen? See, this was a recent article by Jessica Santa which warned the higher risk of COVID infection. Dr. Pato, I think, believes in community spread of COVID as a treatment strategy. Beware, COVID is still mutating and China is still under lockdown. So we should not have selective amnesia when we are having double pandemics, TB, COVID, and we went back several decades in the TB control. So extending our imagination, if we start immunosuppressive or all HLA B27, side effects shorter, TB reactivated, Dr. Patha will start ATT immunosuppression. Then the patient will get COVID, then we'll go to ICU. And who will bear the cost of hospitalization? Will insurance cover? Will court of law rescue? Lawyer will ask, you have started a treatment against the standard of care. And the judge will ask, why did you not try other strategies reserved for recurrence? And the hammer will appear like it is hitting on our head. Be very careful. There is something difference between expectation and reality. So I'm ready to quit this case if there is a randomized control trial on primary immunosuppression versus secondary immunosuppression in HLA B27. Unfortunately, there is nothing in this literature. Thank you so much.
Thank you very much, Dr. Murugan. That was a truly sizzling debate by both of you. And besides ophthalmology, I really enjoyed the way you all dealt with the topic. That was nice. And but then this session is also a PG update series. So I'm going to ask a very basic question to Dr. Ratnam. The question is, what are the basic investigations you would advise before we start patients on immunomodulation? How are you going to follow up these patients? And what are the investigations you would do on the follow-up also?
Actually, as these two people informed, doing HLA typing is not at all needed in clinical practice. It's only for research purpose. So I never do HLA typing, which says that 90% of them are positive, 10% of them are negative, and both can have eye involvement. Then there is no meaning in doing that. Whenever HLA B27 patient comes, if by chance
mute themselves, please.
Yeah. If the patient has neck pain or low back pain, I directly go for radio diagnosis and I do CT. I get rheumatology opinion. One most important thing, topically we can use topical steroid, periocular steroid, and most important dilating agents. And this alone we can take, then get the rheumatologist's opinion for systemic immunosuppressants. Because if we give oral steroids, they always say that they have reactive arthritis. So never give oral steroid to HLA B27. Directly we have to handle with the topical steroid, cycloplegic, periocular steroid, get rheumatology opinion, do CT scan of the spine, then with the rheumatologist help, we'll go for immunomodulators. if the systemic problem is severe. If there is no systemic problem at all, topically we can manage, topical and periocular.
Dr. Avinash, would you want to add something to it, or shall we go on to the next question?
I think we can move on. I think.
I just had one question, Ratna Madam. How commonly do we see the posterior segment manifestations in Indian scenario, especially when it comes to the vitritis or papillitis or panuveitis?
It's very rare.
Partho sir.
It's very rare.
It's very rare.
Occasionally we can have macular edema. Otherwise, it's very, very rare.
And if yes, then
Dr. Srinivas, very relevant point actually. So imagine a case of HLA B27 coming to your OPD. So most of the time there will be severe pain, photophobia, congestion. So hardly we examine the posterior segment properly, or we don't do angiography also. So if we examine the patients, and there is one study I forgot. So if you do angiography, there are evidences that there can be angiography. Angiographically, you can see the vascular inflammation. So it's very difficult to say because, as Ratina Madam said, it is clinically relevant posterior segment inflammation may be very, very rare, but we don't know the actual picture.
If they are associated with reters or reactive arthritis, you see more of intermediate uveitis. In these patients with HLA B27, and they, I would just like to add one thing. Normally, we also get a CRP done in patients with this. So if the CRP is on the higher side, then I think MRI is a good option.
We do ESR and CRP.
But I think Dr. Bala has diverted the topic. It's not about doing HLA B27 or not. Whether we use immunomodulation and what are the indication, ma'am. Ratina ma'am, when you start immunomodulation?
Only when they have severe systemic involvement.
I have treated
can I just
patients
add?
with recurrent,
there is a recurrent attack.
Recurrences,
multiple recurrences. I have seen that. May
3 to 4 recurrences per year, I think is a significant thing.
And usually when there is too many recurrences, invariably they have systemic complication. Both go in hand.
One more point is, ma'am, if the patient is a steroid responder, so then it is immunomodulation. Absolutely.
May I add a point?
Yes, sir.
We have, you can briefly tell because we have 4 more speakers.
Yeah. I just want to tell you that I have patients having 10, 20, 15 recurrences. Such patients you cannot live like on topical steroids. I have seen these patients do well with methotrexate or sulfasalazine. Their recurrence rate is reduced and they're much more happy.
I agree, sir. Too many recurrences, immunomodulator. But these patients invariably have systemic finding also.